Medurstand, Understanding Medicine.
I'm Professor Azizur Rahman, and in continuation of our videos on ECG, this is the second one. This is the curriculum, and you have attended maybe, I'm not sure, but we have covered introduction, and today we're going to take up this second one. How to determine cardiac access. Before we learn how to determine cardiac access, we need to understand what are cardiac access and what is its clinical importance. I must admit that its clinical importance is relatively limited. Of course, it has its role. In certain conditions, it may be very useful, but I wouldn't call it of great importance. But it is very interesting to know what are cardiac access and how do we determine them. Uh, as you can imagine, we have three planes: frontal plane, horizontal plane, and sagittal plane. Now let me demonstrate what I mean by frontal plane. Frontal plane, if you imagine my body, and this plane, if you imagine this plane, this is frontal plane, and every plane has different ECG representation. Horizontal plane would be like this one. If you cut a section of my body like this, that would be horizontal plane, and if you cut a section like this vertical, this would be sagittal plane. These are the words we use in anatomy. So front, and also in radiology: frontal plane, horizontal plane, and sagittal plane. When it comes to cardiac access, it is, I think the frontal plane is the most important because it is actually frontal cardiac access. Now, frontal plane is represented by only limb leads. So this is very, very important. Whenever we determine cardiac access, we only refer to limb leads. We ignore precordial leads because precordial leads are relevant when we talk about counterclock rotation or clockwise rotation. So here in this lecture, in this part of our ECG discussion, only the limb leads would be important. Horizontal plane is represented by precordial leads. You know precordial leads V1, V2, and then V3, V4, V5, V6. They pass across the heart and they represent horizontal plane. So it might show you if heart is electrically counterclockwise or clockwise rotated, but not relevant in cardiac access. Sagittal plane would be represented by esophageal leads. Now that is not used in normal clinical practices, but in experimental lab, and they may be used, and they, because esophagus happens to pass just behind our heart in a curved fashion. So if you place different electrodes in the esophagus, then they would represent a sagittal plane. That of course not important for routine clinical practices. It might be important if you want to determine the loop, the axis in all three dimensions, but not in our routine clinical practice. So we will be concentrating on frontal plane and limb leads. All right. Now, I think we need to understand this picture before we proceed further. We have 6 limb leads, and 3 of them, lead 1, lead 2, and lead 3. These are bipolar leads. By bipolar leads, I mean that it has got 2 poles. One is positive and the other one is negative. And which one is positive, which one is negative, this is all determined by convention. There is no, I mean, somebody who invented this concept, he just assigned positive sign to this one and negative sign to this one, and there is no other, I think, logic behind that. So the first lead, lead 1, is placed between right arm and the left arm. Okay, and the left arm is positive. This one is negative. This is lead 1. And this is lead 2, which is placed between right arm and left leg. In this case, left leg is positive, right arm is negative. And limb lead 3 is placed between left arm and the left leg, and the positive terminal is the left leg. Okay, so these 3 are bipolar leads, one positive terminal, the other negative terminal. And current flows in one direction, that will be registered as upward deflection in the positive electrode and negative deflection in the downward deflection in the negative electrode. Now, these are three additional limb leads. These are unipolar leads. Why do we call them unipolar? Because they have one positive terminal, the other one is neutral, which is imaginary in the center of the body. It is actually, I think, made by combining all three remaining limbs. For example, in the case of AVF, AVF will make the positive terminal, and all three leads combined would represent the neutral. But I think for our discussion, we just assume that AVF is unipolar lead and positive terminal is in the left leg. And this is actually AVL. AVL is again unipolar lead and the positive terminal is left arm. And this is AVR. AVR is unipolar lead and this is represented by the right arm. So we have now 6 leads, 1, 2, 3, AVR, AVL, AVF, all 6 leads, they represent frontal plane. Now I'll show you, if you just consider these 3, there would be 60-degree angle, and if you add these one also, there would be 30-degree angle between these leads. And I'm going to show you this, and that will really help in the understanding of axis and how to determine cardiac axis. This is the lead system. We have already discussed limb leads. We have bipolar 1, 2, 3, unipolar AVR, AVL, AVF. A is actually augmented. Somebody discovered this technique that by making this arrangement, they can augment a certain leads. So these are the augmented leads. Now this is the picture. You know there is convention, this color coding. Red color represents right arm. The electrode which is attached to the right arm would have right color, and the yellow is the left arm, green is left foot. Now right foot is actually neutral. When we imagine a triangle like this one, you imagine that person has got only one leg, and that is the left one. This one is not existing, so then you can imagine a triangle. It would not be a very symmetrical triangle, but this is how this works. Now this is again represented by the same. Lead 1 is between the right arm and left arm. It is here. And lead 2 is between right arm and left leg. It would be like here. And limb lead 3 is between left arm and left leg. It would be like here. And I'm going to show you in some more detail. This is, for example, this one is lead 1. Now you please note down that the arrow of the head of the arrow is on the left side because that is positive terminal. Okay, the head would represent the positive terminal, and current is like flowing in this direction. And now this is the lead 1 and this is lead 2 between right arm and left leg, and in this triangle it will make this arm, and the positive terminal is here. Similarly, the limb lead 3 is like this. So this is a triangle. Heart sits in between. For our convenience and for better understanding of these axes, we are going to move these 3 arrows centrally to make a shape. Now you all know the vectors, if you change its position, it does not change its effect as long as you do not change its direction. So let me move all these 3 arrows centrally like this one. Okay, now you can imagine we have heart in the center. We have 3 lead system, 1, 2 and 3, all meeting in the center, and angle between any 2 adjacent lead would be 60 degree. Okay, so this is considered 0, and this is again convention, and we will count from this side. This is 0, this would be 60, this would be 120, this would be 180, and like minus 150, minus 60, like that. Please excuse me if I said it wrongly, but every angle is 60 degree. Now we then add augmented lead to further refine our diagram. so these three bipolar limb leads are coded black here. 1, 2, 3. But we have added three more leads into this, and they are coded this yellow or orange. This is AVF because this is the positive terminal is foot. This is AVL because positive terminal is left arm. AVL, L is left arm. And this is AVR because the terminal here is right arm. Okay, let's proceed further. So now we have the same picture, but every two adjacent leads have 30 degree. Now this has got actually background when we determine cardiac axis. Now we have a 12 lead system or 6 leads with two arms with the 30 degree angle in between two adjacent leads. Now these are, we have talked about limb leads. They would be relevant to today's discussion, but that just to complete the lead system, then we have precordial leads. We have V1 to V6. V1 is placed in the fourth intercostal space, just right to the sternum. V2 is the same intercostal space on the left side of the sternum. Then V4 is the cardiac apex. V3 is in the middle on this line, somewhere in the middle. And V5 is in the anterior axillary line. And then V6 is mid-axillary line. Theoretically, we could extend these to V7, V8, V9 to represent the posterior wall, but practically that is not done. And we don't have these leads on the right side, but we could have, like for example, we could have V3R. This corresponds to V3 on the left side. Since it is right side, we would call it V3R, V4R, V5R. They would be relevant when we consider right ventricular infarction. In conventional 12 lead ECGs, these are not included. Now we coming back to the same picture. Now this is the picture. Every person, every cardiologist, every physician actually has this picture printed in his mind, and that is required when we determine cardiac axis. Now this is like you can see 6 ECG leads. This is 0, this angle is 0, 30 degree, 60, 90, 120, 150, 180, and then in minus. Now I'll show you how these angles are represented by various leads. This is 0 and 1, and this is of course lead 1. This is positive terminal because this is the lead 1 has this convention, the positive terminal left arm. And this one is lead 2 at a degree of 60 degree. At an angle of 60 degree. This is limb lead 3 and this is at the angle of 120. I think this is revision of what we already learned. But please bear with me. Revision is not bad. I think that is how you understand things better. So in this picture, we have now placed 3 leads representing our frontal cardiac axis now with 60 degree angle. Can you notice this angle? There are numerous small arrows, but one big one. This means that these small arrows are actually this depolarization process. It passes through various angles and directions, but ultimately it makes one big mean axis. This is what we're going to determine. Okay, so we have now 3 leads, 1, 2, and 3, and now we're going to insert augmented lead in this picture. This is AVR. Now please note down this AVR has the same color as lead 3. And I'm going to show you what is the philosophy behind. Okay. Now we have AVL. AVL is here and this is the same color as limb lead 2. Now we have AVF. AVF has the same color as lead 1. Now so we have actually 2 sets of limb leads. 1, 2, 3 are the bipolar, and then AVL, AVR, AVF unipolar. But they have all fitted in this picture, making angle of 30. Now, there are pairs actually. I told you the color coding, there are actually two pairs. Now, pairs, now what is the concept of pair? 1 and AVF make a pair. 1 is this one, AVF is this one. So they make a pair. Why do they make a pair? Because they are at right angle to each other. Now we will use this concept when we determine cardiac axis. So pair of 1 and AVF, they are at right angle to each other. Then we have pair 2 and AVL. This is limb lead 2 and this is limb lead AVL. So they are again at right angle to each other. That is why they are coded in the same color. This is 3 and AVR. Limb lead 3 and AVR, they are coded in the same color. Now, how do we figure out how? I think there's a simple way. If you list these leads 1, 2, 3, AVR, AVL, AVF in that sequence, and then if you at 1 and AVF like this, going like this, is one pair, going this way is another pair, and this line is straight. So 2, 2 AVF. I think you can imagine this one in your mind, and 1 AVF one pair, 3 AVR second pair, and 2 and AVL third pair. Okay, I hope you are following what I'm trying to explain. So this is the cardiac axis. We have come back to the same picture. During one cardiac cycle, current actually flows in numerous directions, and ultimately there is a sum of this. So since the origin of current is here, which is SA node, which is present in the upper part of the right atrium, and main muscle mass, the depolarizable mass, is on the side of the cardiac apex. So current will be actually flowing from this to this. Net current flow will be in this direction. That will be represented by this axis. Now, if you remember that picture, 0 is here and 90 is here, 180 is here. So this would be around 60. So our cardiac axes are plus minus 60. Of course, there's a range from minus 130, from minus 30 to plus 90 or plus 105 or plus 110. Various authorities, they use different cut points, but there is a wide range of normal cardiac axis. I think before we go further, we have to understand this concept. By convention, if current flows from the negative to the positive terminal, and you can imagine lead 1 here, lead 1 is placed like this, positive terminal on the left side and the negative terminal here. Now, if current flows in this direction, the electrode which is placed close to the positive terminal would record this ECG wave as positive deflection. And the current, the electrode which is placed on the other side, and the current is flowing away from this electrode, and the same electrical phenomenon here is recorded as downward deflection. And this electrode is placed in the middle, so partly current is flowing toward it, so the initial part is upward, and then current is flowing away from it, and the remaining part is negative. So this is the basic principle we will use in determination of cardiac axis. A positive deflection would mean the current is flowing toward the electrode. A negative deflection would mean the current is flowing away from the electrode. And a biphasic biphasic ECG complex would mean that the current is actually flowing across this. Now, this concept we will use when we determine cardiac axis. Now, this is now the principle on the background of what we have discussed. This is the 3 pair, 1 and AVF, 2 and AVL, 3 and AVR. And this is that lead system. One pair is lead 1 and AVF, coded red. The other pair is orange or yellow. This is lead 2 and AVL. And the third one is white. This is limb lead 3 and AVR. You don't have to memorize, just see the picture, and you from the location you can figure out. And this is 0 and this is 90, this is 180, and then this goes to 30 and 60, and you can calculate the rest of the thing, 120, 150, like that. Now we will, when we determine cardiac axis, we will make 3 observations and then we'll draw 3 inferences, and ultimately we reach a conclusion of cardiac axis. Now the first observation, find isoelectric QRS. You scan limb leads. We have already discussed, and I'm going to repeat it. When we determine frontal cardiac axis, we will only consider limb leads. So scan all limb lead from 1, 2, 3, AVR, AVL, AVF, and see if you can find an ECG complex which is more or less like this one. Isoelectric means part of it is above, part of it is below the isoelectric line. Doesn't matter which part is above, which part is below, as long as both are almost equal. So this one, suppose in our exercise, we imagine that we find such a complex in AVF. You could actually find in any lead, but suppose for the purpose of our discussion, we scan all limb leads and we found an isoelectric complex in AVF. And this is AVF. And what is the inference we draw? The inference we draw is that current must be flowing across this at right angle to this one, and this is the axes are along the paired lead, and paired lead in this is 1. It is along. So as yet we do not know whether current is flowing toward this or this, because all we know that it is along this one. Okay, so from the first observation, if we find an isoelectric complex in AVF, we can draw an inference that current is flowing across lead 1, because lead 1 happens to be at right angle to AVF. Now let's go to the observation number 2. That is, go to paired lead, and this is lead 1. Okay, and see if the complex is predominantly upward and or the predominantly downward. It has to be predominant upward or predominant downward. It can't be biphasic. That is the physics of ECG. So you would find either this one or that one. This would imply that current is flowing toward the positive terminal of lead 1, like here. And this would imply that the current is flowing toward the negative lead terminal of lead 1, that is 180. So that is the inference we draw. Either if it is positive, the angle, the axes are close to 0. And if it is predominantly downward, the axes are close to 180. So from this second step, we have now further closer to our axis determination. With this, based on what type of axis what type of complex we see, so we have cardiac axis either close to 0 or close to 180. And now we will go to a step further. Step further is that you go back to the original lead. In this case, in our example, the original lead was AVF, and see which deflection was bigger. Was the upward deflection or the downward deflection was bigger? Here we just considered one thing, that it is almost isoelectric, but now we examine it in more detail and see which deflection is bigger. And you would agree with me that the downward deflection is bigger. Now when we consider the size, we also consider the breadth also. So suppose you have upward and downward deflection of the same size, but one of them is broader, that would be considered bigger. So in this case, the downward deflection is bigger. That means, since this is AVF, the current is predominantly flowing toward the negative terminal of AVF. So we had determined that axes are close to 0, but based on this, we determined that it is more toward the negative terminal AVF, and negative terminal AVF is this one. This is AVF, this is the negative terminal. So 15 degree towards the bigger deflection. It could be toward this, or it could also be, if this was a different case, if it was this one, then we would make plus or minus to 180. But in this case, we would, since the downward deflection is bigger, then we would have to turn our angles by 15 degree. Why 15 degrees? Because 15 is middle of 30 degree. and two adjacent leads are 30 degree. So we will turn the axis by 15 degree toward the minus terminal of lead AVF. So that would be our axis. Okay. I hope I was able to make the concept clear. Now we are going to do the exercise. Okay. So our first step is to find an ECG where upward and downward deflections are equivalent. We have this picture for reference. 1, 2, 3 AVR, AVL, AVF. So I think 2 can qualify. This is the complex. This is actually P wave. This is the QRS complex. Upward deflection, downward deflection are almost equal. This could qualify, or AVF could also qualify, upper and downward. So I'm going to use AVF just because in the previous discussion we used AVF. So this would actually make the concept clear. So in this case, the downward deflection is AVF has isoelectric. So we are going to cover this part because these do not matter. We are going to focus on a limb lead. So we cover this and we bring up this picture for the reference. So from this observation, AVF is isoelectric. We determine that cardiac axes are along lead 1. All right. So you're right. So along this arrow has heads on both sides because it could be in this direction or this direction. So far we do not know. We only know that axes are at right angle to AVF. AVF is like this and it is at right angle, lead is 1. So we know that axes are in this angle, this line. Now the second point is we go to the lead which is at right angle to AVF, and that is limb lead 1, and this is limb lead 1, and we have to see if the QRS complex is predominantly upward or downward. In this case it is predominantly upward. So that means predominant upward means that I have removed this arrow. So we have determined that axes are close to 0. Now the third step, we will go to the AVF again and see which deflection is bigger. In this case, the downward deflection is bigger. So we will turn the axis by 15 degrees to the minus electrode of the negative electrode of AVF. So this is it. So in this case, cardiac axis, mean frontal cardiac axis in this case is minus 15. This is how this exercise goes. So with exercise, we're going to have one more exercise and then I will demonstrate you another method. There are actually two methods. Maybe this one is, I think, philosophically better. So I demonstrated this one first. The other one may be easy for you, and just bear with me and I'm going to show you another method which is easier. So let's repeat this one in another ECG to make the concept better. So this is another ECG and we cover this part, and let's see which of the 6 leads we have isoelectric. Yes, you're right here, AVR. Okay, AVR has got an isoelectric or biphasic QRS complex. So AVR, and AVR is this one. It is written here, but you should remember by now that this is AVR. Okay. So from this observation, we have determined that the axis must be at right angle to AVR. Okay, because isoelectric complex means that the current is flowing at right angle, and this is AVR, and the lead at right angle is limb lead 3. It is written here, limb lead 3. Now, so far we have determined that the cardiac axes are along limb lead 3. It could be minus 60 or it could be plus 120. To determine which one is correct, we go to the lead which is at right angle to AVR, and the lead at right angle to AVR is limb lead 3. And in this case, you have seen that the QRS is predominantly downward. That means the axes are toward the negative terminal of limb lead 3, and this is the negative terminal of limb lead 3, if you remember your picture. So we have determined, we have removed this arrow, the x's are now close to minus 60. First we estimated to be close to 0. Now we have estimated to be close to minus 60. In the third step, we have to go back to AVR again, the first lead, and see which one is bigger. In this case, AVR, the downward deflection is bigger. Since downward deflection is bigger, then we means AVR, this is the positive terminal and this is the negative terminal of AVR. So we have turned our axis by 15 degree to the negative terminal, to the positive terminal uh, of AVR. So this is actually axis minus 45. Minus 45 would be the final axis in this case. Now let's proceed further. Now this is the method number 2. I think, let me say that this may be easier. Now this is a different principle. The basic physics is the same, but there's another approach. This is that picture. I have drawn this for you, and this is 0, 30, 60, 90, 130, 150, 180, 1 minus, and you all know which leads represent which one. So this time we take a different approach. We find the bigger deflections. Which one ever is deepest or tallest? Okay. So lead 1, 2, 3, AVR, AVL, AVF. I think 3 is fairly tall. 3 is fairly tall. So we select this limb 3 and we draw an arrow. This is limb lead 3. Right? I don't want to repeat again and again. This is limb lead 3. Since it is upward deflection, we draw an arrow along limb lead 3, the positive terminal. And the length of this arrow should be equivalent to or proportionate to the height of this QRS complex. And when we determine height, we actually subtract the negative part also. I'll just demonstrate it shortly. So this is first step. The second step is you choose any ECG, but the one which has predominant QRS, and I think theoretically somewhere at a distance, not this one, at a distance, like we can take this lead 1. In lead 1, see the complex. Complex is predominantly downward. There is a positive component also. So when we find the actual depth, we will have to subtract this part from this part, and we will draw an arrow toward the negative terminal of lead 1, which would be proportionate to the net algebraic sum of this QRS complex. So there would be an arrow drawn like this. This was along the positive terminal of lead 3, and this is along the negative terminal of lead 1. Why? Because this is upward deflection, this is negative deflection. So if you have done this much, the rest of it is very, very easy. You draw a line, you just draw a line which is at right angle to this one, and you draw another line which is at right angle to this one. So two lines are drawn, and the point where they meet, that is actually the cardiac axis. This arrow would indicate cardiac axis. It is minus 135. I think what is between 120 and 150? Yes, minus 135. So this is how we calculated the cardiac axis. Sorry, plus, not minus, this plus. This is 0 and this is plus quadrant. So this is plus 135. So this is actually right axis deviation. Now we will do one more exercise to practice this method. This is another ECG and we have the same picture. Now let's see which one we choose. It could be upward or downward, but it has to be a significantly big deflection. Which one do you think is the right one? I chose lead 3. Lead 3, 1, 2, 3. 3, 1. Okay, lead 3. As I told you earlier, we had to subtract this part. So this is the line arrow drawn along the negative terminal of limb lead 3 because it is downward deflection, and the length of this arrow is proportional to the depth of this QRS complex. And the second one, maybe lead 1. Yes, lead 1. In this case, predominant deflection is positive, so we draw an angle like this. And again, we would draw lines at right angle, and we combine these, and then we have the axis of minus 45. So this patient has got axis of minus 45. There is another ECG abnormality here, but I'm not going to confuse you with that. We are just discussing axis in this case. So we have determined cardiac axis to be minus 45. So I hope you had some understanding. I don't actually believe in those shortcuts. There are some people have made some shortcuts. I don't believe in them. I have never followed shortcuts in my life. I want to understand the disease process, and that is what I want you to do it. That is the whole concept of my channel, understanding medicine, understanding ECG, interpretation of ECG. So I hope you have understood both methods. You can follow whichever you find it easy, but it is best to practice one, at least to start with. Now this is another one. I would not go into the detail, but if you have practiced it, I think you should do it mentally. Now, for example, this part is recovered, and if I do mental calculation, I would be able to come up with the correct answer, and the correct answer is 105. The x's are just on the right extreme of normal range. So this is the cardiac axis. Let me just go one step further, and we are going to about complete this module. Frontal axis deviation. So if mean axis fall in this range, the mean frontal axis fall in this range from minus 30 to plus 105 in this case. I told you different authorities, they use different cut points. Some use 90, some use 105, some use 110. So, but I think we can imagine 105 for the sake of discussion. So any angle, any cardiac axis falling in this range would be normal frontal cardiac axis. And if axes are on this side, this would be right axis deviation, more positive than 105. Okay, this is right axis deviation. And then if the axes are on this side, this is called left axis deviation. This concept would be applicable in, I think most importantly, in fascicular blocks, but also in bundle branch blocks, also in hypertrophy pattern, also in dextrocardia. So I think at this stage, we have determined, we have learned how to determine cardiac axis. Mean frontal axes are like 60 plus or minus 30, but the range is this one. A axis deviation would not necessarily mean that there is serious problem. There could be gross axis deviation, or there could be no axis deviation. The patient, that does not determine the severity of heart disease. Now you may have noticed that there is an area where there is no, this part is actually no man's land. You could describe it as extreme right axis deviation or extreme left axis deviation. There is a part here which is not considered anyway. This is called no man's land. So, ladies and gentlemen, this was my view on axis determination, and I demonstrated two methods of determination of axis, and I have explained the basic physics. I gave you the examples. Now you pick up ECG strips and practice it, and I'm sure it would be very, very rewarding experience. This has been Professor Azizur Rahman from Medurstand. Please follow me on my subsequent videos. I'm going to cover the entire ECG module and of course other topics in medicine. But now since I've started ECG, I'm going to finish all 25 modules. You can watch these videos, you can download them, you can share them, be free, and use them as you wish. Thank you very much, and see you next video.